want to welcome you all and joining in to our webinar presentation for Fight Colorectal with Dr. Fakih to talk a little bit about liver metastases and spread after a colorectal cancer diagnosis and spreading to the liver. We're going to actually be talking a little bit about the medical research and the science as well as treatment available. Just a quick reminder that if you have questions throughout the webinar, please go ahead and type those into the text box. We will be asking, or Kevin McAbee will be moderating the question and answer session after we move forward with the presentation from Dr. Fakih today. So we're very excited to just remind you all that we're also going to be doing a live Twitter chat and feed at #CRCWebinar. You'll also be getting an email after the webinar today, just the survey to ask how we did, some recommendations for future webinars, as well as any information or questions that you have. So just again, the question and panel is at the right side of the screen, so I'd love to have your questions as we go through today's webinar. So next slide. Just want to remind you all, as we get ready to move forward, is that we still are very much a foundation and entity that's very much dedicated to donation of funds and funding of science, where a number of our contributions and those who are donating to us, that we really do put a lot of that money towards science and looking at specifically our LISA fund, which has raised thousands of dollars to look at stage 3 and stage 4 colorectal cancer research. Several of us were fortunate enough to attend the AACR meeting a couple of weeks ago, where our latest grant recipient received the award, and it's such an honor to see great work happening there. And then, of course, with all of you who are donating these dollars, thank you so much for your contribution. So very proud of the LISA fund and our work. So just want some, again, to remind that we are a very, very interactive and proactive group. So join us and posting, liking, commenting, sharing at Fight CRC at our page. Join our page. Kevin has a bit of information about Facebook and how to join our Facebook group for patient resource as well. We need you really to be involved in the fight to make sure that we're bringing the voice and the active voice of survivors, people who are involved in the fight directly, such as co-survivors and medical folks, to really ensure that we really advance the treatment options in the research in this area for late-stage disease specifically. Next slide. Just want to remind everyone today that the information that we're provided is for general information and education purposes. This is in no way to directly substitute for medical professional advice or to replace your direct clinical care. If you are ill or if there's something that you're not feeling well and need to ask immediate questions, we ask that you call 911 for an emergent or visit an emergency room or talk to your doctor immediately. We never recommend or endorse any specific product, physician product, or treatments for any condition. And just a general reminder that Dr. Fakih, as well as none of the Fight CRC staff, are able to provide direct guidance about any specific medical treatment or care during the course of questioning today. Next slide. So with that, I'd really have the opportunity to introduce Dr. Fakih, who received his bachelor's and did a lot of his medical doctoral work in Beirut, and he did his medical residency in internal medicine at Wayne State, and a fellowship in hematology and onc at University of Pittsburgh, and then currently was recruited, or actually was recruited to City of Hope in November of 2012, specifically working in the GI onc section. And then he was appointed to the interim chair of medical oncology at City of Hope. His research really focused on drug development and prevention of colorectal cancer. He's really looking towards developing strategies to optimize biomedical and specific targeted therapies for therapy in colorectal cancer, and then definitely implications for liver with the work that he's done. And he's published many peer-reviewed articles and serves on editorial boards for a number of scientific journals. So we're very excited to have Dr. Fakih join us today. I want to send a special thanks to our Fight CRC team, Michael Sola, Kevin McAbee, who are working with us today to share information about the webinar, and then we will be going ahead and then doing a Q&A session post-webinar. So with that, I'd like to go ahead and have Dr. Fakih lead us through today's presentation.
Thank you, Andrea. Let me just pull my slides here. Here we go. Well, it's a pleasure to be here today to present to our audience, and thank you all for taking the time out of your busy schedule to be here. I know you must be very passionate about this field and about fighting colon cancer, and trust me, so am I. I will be spending the coming 50 minutes to talk about emerging approaches for unresectable colorectal liver metastases. Please be free to put in for any questions at the end. I will try to answer as many questions as possible. So these are my disclosures. So before we start, I would like to kind of take you as to where we are in colorectal cancer and what is the state of colorectal cancer. Close this. So as you can see from this slide, we have made some progress in colorectal cancer. And what you can see on this slide is a decline in the rates of colorectal cancer and number of new cases per 100,000. In 1992, you can see that it was almost about 30% more colorectal cancers in the United States per 100,000 individuals than it is now in 2015. And this trend has, continued in the last 20 years. And the reason for the decline in the number of new colon cancers is really accredited predominantly for colonoscopies and screening measures. So if anything makes a difference, the thing that makes the biggest difference in the fight against colorectal cancer is performing screening procedures, namely endoscopies, with colonoscopy being the most sensitive. However, there are many other measures of screening available as well and in development. And you can see that in parallel with this decrease in the new cases per year, there has been a decline in the number of deaths from colorectal cancer in the United States. It is estimated, however, that still about 50,000 individuals die from colon cancer or colorectal cancer a year, and that is number 2 cause of death from cancer in the United States following lung cancer. So still a very, very important health problem that we have to tackle, and clearly we have decreased the incidence, but it's important also to find ways to cure and prolong the longevity of patients who present with metastatic disease. This slide shows you the stage of presentation, and on the left hand you can see that the majority of patients will present with either regional disease or local disease. This is localized disease, meaning the tumor is localized to the colon or to the rectum. Regional disease means it's gone to a gland or what we call lymph node next to the colon or rectum. And metastatic disease or distant disease means the tumor has spread from the colon or rectum to an organ. And typically in colon cancer, the most dominant site of metastases is the liver, but also lung is not uncommon, as well as peritoneum and distant lymph nodes. And this is important because what we want is we want to catch colon cancer early on, because if you look at patients who present with stage 1 or stage 2 disease, the 5-year overall survival is 90%. And despite the advances in metastatic disease, if we are not able to control the liver or undergo, perform metastectomies, resect metastases, the 5-year survival, unfortunately, is limited to about 15%, even with chemotherapy. So more has to be done in the fight against this cancer. So this is a chart that shows the distribution of colon cancer, and you can see about 136,000 patients present with colon cancer. Now, as we said earlier, about 20% of those to 25% at the time of presentation present with stage 4 disease, meaning even when they're diagnosed at the first time to have colon cancer, it has already spread in 20 to 25% of patients. Now, 70 to 75% have no spread at the time of presentation or diagnosis. But unfortunately, despite surgery on those patients and despite chemotherapy, about 1/3 of those patients, 1/4 to 1/3 of those patients will actually relapse, and typically the relapse is not regional. The most common relapse in patients with resected colon cancer is not within the colon, but is spread in the liver and in the lungs. And those patients were never really cured, but really patients who had microscopic metastatic disease and they didn't know it, and the doctors didn't know it because there were no sensitive enough assays to determine that it had spread. And with time, these tumors that are microscopic will grow and develop measurable disease in the liver or in the lungs or in the peritoneum or other places. And therefore, if we look at the overall population, the 136,000, eventually, unfortunately, about half of those patients will deal with metastatic disease, either at presentation or after initial diagnosis with a recurrence. So approximately of those who will develop a recurrence, 60% of those patients who have distant disease, who have metastatic disease, have liver involvement. And if we look at patients who have recurrence of disease or who present initially with metastatic disease, and we follow those up for years and years, those individuals who pass away from colorectal cancer, about half of them do so because of liver involvement and because of liver failure. And the point of this slide is to emphasize that it is important to control liver metastases in the fight of against colorectal cancer in instances where cure is not feasible. So when we have a patient with metastatic colorectal cancer who presents to our clinic, the first thing I have to evaluate is, do they have liver metastases or not? And then the next question on my mind is, are these liver metastases resectable? If the patient has liver metastases, spread of colon cancer to the liver, and it has not spread elsewhere, or has minimal spread elsewhere that also can be removed surgically, then if the tumors are resectable in the liver, then that patient should undergo a curative intent surgery. So at one point, that patient should be considered for surgery to render that patient in a clinical remission. And then we have patients who, what we call potentially resectable, but not resectable right now, meaning these patients present with a lot of metastases in the liver, and you cannot technically remove these metastases and leave enough liver behind to sustain the patient. And however, if you reduce these metastases significantly with chemotherapy, you could potentially turn a patient who is not resectable resectable. So that's called potentially resectable. And then we have patients who, at the onset of presentation, have significant amount of disease in the liver and elsewhere, say, numerous pulmonary metastases, peritoneal disease, as well as liver metastases, and those are considered non-resectable and not potentially resectable. And it's important when we see those patients and they come into our clinic to determine upfront which category does this patient belong to, so that the more appropriate management is taken. So we're going to start with resectable disease and management of resectable liver metastases. So this is a picture of the liver, and the liver has 8 segments. And at this point, what we consider resectable for liver metastases is the following criteria. Resectable means the surgeon can remove all the tumors and leave no tumors behind. So that's number 1 criteria that has to be satisfied. If the surgeon goes in and removes 3/4 of the cancer and leaves 1/4 behind, that is not something that will help the patient. All the tumor has to be resected. The liver has to be free of residual disease. So that's number 1 criteria for ability to resect. The margin around the tumor, meaning where the surgeon cuts around the tumor, does not have to be very big, and even having a couple millimeters, 1/10 of an inch around the tumor, free of tumor removed, is adequate. The second most important thing in defining resectability is that after the surgeon is done removing the cancer in the liver, there ought to be enough liver left behind to sustain or to keep the function of the liver going. The liver detoxifies the body, and even though the liver does regenerate, there is a minimum amount of liver that needs to be left behind, and that's approximately 30% of the liver has to be left behind after surgery to be viable or to sustain the patient. And actually, if a patient had been treated extensively with chemotherapy, sometimes it's not feasible to resect more than half of the liver. The other thing that is important with the resection is to keep adequate inflow and outflow So there ought to be still an ability of the two segments of the liver, the minimum two segments of the liver left behind, to drain the blood out of the liver into the circulation, and also to obtain blood, pink blood from the artery, from the hepatic artery, and there ought to be also supply from the portal vein. So there ought to be adequate circulation sustaining the residual liver. In patients who have few lung nodules, that's no longer an exclusion for liver resection, but obviously for somebody who has extensive extrahepatic disease or disease outside the liver, such as bone metastases, or say 10, 20 spots on the lungs that you cannot resect, that patient is not going to benefit as much from a liver-directed therapy with surgery per se. And so limited extrahepatic disease, limited disease outside the liver that can also be removed is okay and should not exclude a patient from a surgical approach. So why do we say that patients who have resectable liver metastases should be considered for surgery? The main reason for that is that this is the best shot for a patient to obtain a cure. Unfortunately, chemotherapy is not considered curative for patients with stage 4 colorectal cancer, and the incidence of remission, meaning no visible disease, with chemotherapy is only about 3% with chemotherapy. Although it's very effective in controlling the disease, it's very effective in shrinking the cancer, and in patients who have never received chemotherapy, 90% plus of the time it will work in at least controlling the disease or shrinking it. But making the cancer go away completely with chemotherapy is very unlikely, and obtaining a cure with chemotherapy alone for patients with metastatic disease to the liver is also very unlikely. Sustained cure, where a patient never relapses after chemotherapy alone without surgery for stage 4 colorectal cancer, is estimated to be less than 1% of patients. So we don't typically count on chemotherapy for a cure. And therefore, if there is a strategy, such as surgery, that can provide a shot towards a cure, we always want to take that strategy. So what you see on this slide here are a series of patients who underwent liver surgery for a spread of colorectal cancer over the years. And you can see these series start from the 1980s all the way to the 2000s. And I only selected series that had more than 100 patients. And you can see that liver surgery is pretty safe. If you look at the year 2000 and beyond, it is very rare for a patient to die from liver surgery. Only this series had a 1% mortality, and the others there was no mortality reported. But if you look at the 5-year survival in those patients, the 5-year survival in the modern series of liver resection for metastatic disease to the liver is now about 60%. So we can tell a patient that if we can cut all the tumor out that is in your liver, and if you have no liver, no extrahepatic disease, and we render you in remission after liver surgery, you got a 60%, 50 to 60% chance that you will survive beyond 5 years. And these percentages way exceed what we get with chemotherapy alone, and that's why we really want to optimize the possibility of a surgical resection for liver metastases when feasible. So this is a graph that shows the outcome data, and this is somewhat earlier data than today from Memorial Sloan Kettering, but it is the only data that has looked beyond 10 years in a single institute. And what this data shows that if you look at patients who underwent hepatic resection for colorectal metastases and you look at the 5-year survival, it's about 40 to 50% in these series. And these included patients, with follow-up of more than 10 years. And the numbers and outcome have improved further recently with improvement in surgical techniques and better chemotherapy. But what you can see is that some of the patients who undergo liver surgery for metastatic colorectal cancer to the liver and are alive at 5 years, unfortunately still continue to suffer from recurrences. And it's only those patients who are free of cancer at 10 years and alive at 10 years who never relapse. But nonetheless, it's about 20% plus of patients who undergo liver surgery will be free of cancer at 10 years. And that's something you cannot get with chemotherapy. So how do we approach patients who have resectable metastases from the colon or rectum to the liver and who do not have extrahepatic or disease outside the liver or have very limited disease outside the liver that can be resected? There are two main ways to approach those patients. One way is to start with the surgery, resect the liver metastases. If the primary had already been resected years ago or 1 year ago, or they presented with what we call synchronous disease, meaning the spread is diagnosed at the same time as the colon tumor or rectal tumor. Those patients could undergo their primary tumor resection, or the source of the tumor, either at the same time as the liver surgery, or doing a staged resection, meaning do the liver first and then the primary, or vice versa. Those patients subsequently undergo chemotherapy for 6 months. The other more common strategy nowadays, especially in patients who present with synchronous disease, meaning tumors both in the liver and in the colon at the same time rather than a late relapse, and especially if there's multiple spots in the liver, a more favorable approach for patients with numerous metastases in the liver is to start with chemotherapy first, downstage the disease, control the cancer, try to address the microscopic disease at the same time with chemotherapy before you perform surgery, then proceed with surgery, then do another 3 months of chemo. Both strategies involve 6 months of chemotherapy, and both strategies involve surgery. Those strategies have not been compared adequately head-to-head, and therefore there's no definitive preferable strategy. Depends on the patient, depends on the number of lesions in the liver. But certainly surgery has to be integrated in the management of those patients for more optimal outcome. So just to put some pictures to some of the slides, this is a patient of mine who's 74, who presented with a tumor in the sigmoid colon cancer, in the sigmoid colon, which is basically the portion of the colon just above the rectum. And at the time of presentation, this lady had also a lesion in the right lobe of the liver that you see here. So this lady underwent chemotherapy with 3 months of chemotherapy with what we call FOLFOX, which is a combination chemotherapy of oxaliplatin 5-fluorouracil. That's a very commonly used chemotherapy in the United States. And you can see that the tumor shrunk in 3 months by about 2/3 or more. So significant shrinkage. And this patient then underwent robotic surgery. So using a robot, underwent a small hepatic resection here. And at the same time underwent resection of a primary tumor on the same day. And you can see 1 year later from her surgery here, there is no tumor. This is dense like water. This is basically residual fluid or seroma that is post-surgical in the liver, and this lady is doing well without any evidence of disease. So she did not really require a major surgical resection on the liver, and this was only a wedge resection of a hepatic metastasis. So there are other techniques that can be done for patients who have liver metastases for the purpose of cure. If the tumor is very small, one other strategy is to do what we call radiofrequency ablation. There's a lot of variations on those, such as microwave ablation. And the main concept here is that the interventional radiologist or the surgeon will insert a probe. This can be done under ultrasound guidance without having surgery. Through the skin, we call that transcutaneous. The probe is inserted into the tumor, and then the wires are deployed within this tumor, and then they will emit radiofrequency. And this radiofrequency will basically burn the tumor. And the goal is to burn the tumor with up to 1 to 2 centimeters of normal liver around it so that we do not have any local recurrence. This procedure can be also done laparoscopically. And laparoscopically means we put several other probes through the skin, which basically help with localization of the tumor better, and especially for more challenging lesions or multiple lesions. The procedure can be done also intraoperatively. Now, this procedure is typically done for tumors that are less than 5 centimeters in size. Actually, it's even better to do it for sizes of less than 3 centimeters or less than 2 centimeters. For tumors that are larger, the risk is that there is a high chance that the cancer will not be completely burned and that local recurrence will occur at the site of the ablation. For tumors that are very, very small, 3 centimeters or smaller, then the likelihood of success and no recurrence is very, very high. So when do we do radiofrequency ablation and when do we do surgery? Typically, surgery is preferable. And why is that? Even though there's no head-to-head data, retrospective analysis, meaning looking back at the outcome of patients who undergo surgery alone to the liver, you can see that those patients have the best outcome. So if we're looking at data from MD Anderson here, at 3 years after surgery to the liver for colorectal metastases, 40% of patients had no recurrence. For those who had an ablation and surgery, only about 18% had no recurrence, and those who had ablation alone, most of them had a recurrence. Now, this is really a little bit kind of not very clean data, because obviously probably those with better prognosis who have more limited disease are the ones who are undergoing surgery alone, and those who are getting RFA plus surgery are likely those who have much more disease, and you cannot cut all the tumors, and you don't want to leave inadequate amount of liver behind, so you proceed with radiofrequency. So we may be selecting out more poor prognosis patients or patients more likely to relapse. But nonetheless, we know that local relapses are much higher with RFA than surgery, so when feasible, surgery is the way to go. And this is the overall survival of the same population, and the best outcome was noted in patients who underwent surgery. Radiofrequency ablation still did better than what we expect with historic control, but not as good as surgery alone. So what we look at radiofrequency ablation is patients who are not candidate for surgery, where we are worried about the morbidity of the procedure, how the patient can tolerate the surgical procedure, or in patients who have multiple liver metastases, where you cannot clear the liver with surgery alone, and you cannot really cut too much normal tissue, and therefore you supplement your surgery with ablation. I'll show you a couple of examples later. So that is the gist regarding patients who have metastases to the liver that is resectable. In those patients, surgery, 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 because that's the best outcome. And chemotherapy becomes more of what we call an adjuvant, meaning something to help decrease the risk of recurrence. So now I'm going to take you to the potentially resectable liver metastases. And what is potentially resectable? As I mentioned earlier, these are patients who, when they present initially to us, there's way too much disease in the liver, we cannot perform surgery, but we can foresee and we can imagine that if the tumors in the liver shrink a lot, that these may be amenable then to surgical resection or a combination of surgery and ablation. How often does that happen? So if we look at patients who present with liver metastases, about 15% of those patients from the get-go have resectable disease. 85% are unresectable. If we treat, sorry. If we treat the unresectable disease with chemotherapy, the tumors shrink, and about 10 to 30% of those patients, it will shrink enough to the point that we can resect. So approximately 1/3 of patients who have liver metastases only will become amenable to liver resection or a combination of liver resection and ablation, either upfront or after chemotherapy. Now, this strategy has been shown to be effective even in the early 2000s. This is not new information. This is data from Paul Bruce, which is a large hospital in France, where they do a lot of liver resection for patients with metastatic colorectal cancer. And they looked at 1,100 patients who were deemed not to be amenable to liver resection. And those patients were treated with chemotherapy. And after treatment, 13% of patients, these are the 138 patients here, the tumors were small enough that they could undergo resection and underwent resection. During the same time, during the same time, 335 patients, what you see here in blue, were deemed to be amenable to resection without chemotherapy and underwent resection. So this is an example. This is a patient who has way too much disease in the liver, but not many lesions. And the reason why this tumor is not resectable, it's impinging on all 3 hepatic veins. So this is the right hepatic vein, middle hepatic vein, and that's the left hepatic vein. And we cannot cut all 3 veins. There are only 3 hepatic veins, and one of them has to stay, and one of them has to stay free of cancer. So the goal here is to shrink the tumors so that they are away at least from this left hepatic vein so that you can undergo resection. So that the patient can undergo resection. And this is what you can see after chemotherapy. This is before chemo A, and this is B after chemo. These tumors shrunk significantly. And this is again before chemo and after chemo. And now these are far from the left hepatic vein, and this patient can undergo a curative intent resection, and indeed this patient did undergo a curative intent resection. So this is what we call a potentially resectable patient at the time of presentation, but not resectable. It becomes resectable after chemotherapy. So what do we do clinically for patients who have potentially resectable disease? Basically, we use the chemotherapy that has the highest chance of having major shrinkage. We do not here want to deal with mild chemo that has, for example, only 20% chance of major shrinkage, because then you miss your chance on a curative intent surgical resection. So you choose chemotherapy that has a very high chance of response. And in that setting, we either use a triplet chemotherapy, what we call FOLFOXIRI, with a biological or without biological. FOLFOXIRI has a very high response rate. Based on this trial, the Olivia clinical trial, 81% of patients who received FOLFOXIRI had a major response, and 61% who were initially deemed unresectable became resectable. And if you compare the doublet chemotherapy on that same study, it was inferior in the percentage of shrinkage and also inferior in outcome. So now there is more of a push for the unresectable patients to use more aggressive combination chemotherapies, what we call FOLFOXIRI chemotherapy with or without bevacizumab. Now, this is not a chemo that can be handled very easily for somebody, for example, who is 78 or somebody who has significant other medical issues. So we have to be selective as to who we offer this to. The other way of improving the responses is by adding biologicals, what we call anti-EGFR therapy, and these include the drug cetuximab, the commercial name for that is Erbitux, and the drug panitumumab, the commercial name is Vectibix. Those drugs, however, only work for about 40% of the population. Those patients have no RAS mutation, and also patients without what we call BRAF mutations. BRAF mutations tend to have more resistant disease to all chemotherapy and to anti-EGFR therapy. But there are data now supporting that if we add these anti-EGFR inhibitors to these 40% select patients without RAS mutation, without BRAF mutation, the response rate is better than chemotherapy alone. So chemo plus cetuximab or chemo plus panitumumab may improve the responses further, and therefore may improve the resection rate or the likelihood of converting a patient who has unresectable disease to resectable disease. And these are two trials that have kind of suggested that adding anti-EGFR therapy would improve the likelihood of resection. One is a Chinese trial, randomized clinical trial, and the last one is the trial 80405, a very large study conducted in the United States. And what was noted in that study is that patients who received cetuximab were more likely to undergo liver resection than patients who received bevacizumab in the setting of chemotherapy. So I'm going to show you a few examples as to patients who many would actually consider unresectable. This is a patient of mine who presented with way too much disease in the liver, and you can see on the left side these dark hypodensities, left lobe, right lobe lesions. This is the caudate lobe. So only on one slice here you see 1, 2, 3, 4, 5, 6, 7. This is another slice of the liver, again, February 2014. And you can see, again, quite a few other lesions. You know, these are things that not every center can do, I have to say. We treated this patient with chemotherapy with very aggressive combination with FOLFIRI panitumumab. She did not have a RAS mutation. And you can see the dramatic improvement in her metastatic disease in the liver. Many of the lesions completely disappeared, and some became very, very small, like this one from February now is barely seen in November. Again, this one in the right lobe of the liver, again, barely visible. You can see the same slice of the liver. One lesion, the largest lesion now, is barely visible. The other lesions have disappeared. So this patient actually underwent surgical resection and RFA of multiple lesions. So this isn't a situation where the liver surgeon will go in and say, well, let me look with an intraoperative ultrasound for any visible disease. And you know, obviously you don't want to cut 2/3 of the liver. A lot of the management here was in the form of ablation in this particular patient. So post-surgery, this patient is still is now in a clinical remission since her surgery from January 2015, and is undergoing adjuvant FOLFOX. This is another example I want to show you of what we would have, again, many would have considered unresectable and always unresectable, not potentially resectable. This is a young patient of mine who's in her 40s who presented with extensive liver involvement. This is her scan from February 2014, and you can see extensive amount of disease in the liver. Again, this patient had a RAS wild-type tumor, so no RAS mutation, no BRAF mutation. We treated her with FOLFOXIRI plus bevacizumab, so the triplet chemotherapy that I mentioned has a very high response rate. And you can see, again, an amazing response between February 2014 and November 2014. We basically maximized her response with FOLFIRI, bevacizumab, followed by FOLFIRI, panitumumab, even for more shrinkage. And what the surgeon did is he resected that posterior lobe of the liver that you see here. I hope you can see my pointer. But this was resected, and the rest of the tumors were actually ablated. And so you can see after surgery, this calcified tumor that had shrunk quite a bit from before to after chemo is now ablated, and it's really just a fluid collection. And this is where the surgeon resected the posterior right lobe where there was disease, and you can see a seroma. This is not tumor, this is fluid. Again, that's a site of ablation. So despite the number of lesions that this patient had, this patient was rendered no evidence of visible disease at the time of surgery. And her surgery has been in December 2014, and this patient is still in clinical remission. But we know that this patient has a very high likelihood of recurrence in the liver because she had extensive amount of disease. So this is a situation where occasionally this is where we find a role for what we call regional chemotherapy. And what we did in this patient is we implanted a small pump subcutaneously in the abdomen that pumps chemotherapy to the liver. We're using a drug called FUDR. And the goal of that is to give a very high concentration of the chemotherapy in the liver to try to eradicate the microscopic metastatic disease so that her chance of having a recurrence becomes much lower. So where do we stand in patients? With liver metastases? We all recognize now that the outcome of our patients who have liver disease only is best served when we can get them to no measurable disease left behind, when they have very little disease, so that they do not pass away from liver failure. And therefore, you can see that the number of liver resections in the United States is rocketing up for colorectal cancer. This is about 10 years ago. In year 2000, the number of liver resections for colorectal cancer was 2,000. Now, the number of liver, this is 2011, it's probably higher now. In 2011, it was about 6,500 patients. So tripling in 10 years, in 1 decade, the number of liver resections. And I have to say this is also increasing for lung and other sites of metastatic disease. But the biggest number for resection for patients with metastatic disease of colorectal origin is liver resection. So I've covered resectable, potentially resectable, and now I will talk about non-resectable liver metastases or predominant liver metastases. So patients who have spread to the liver that you cannot cut out, or have spread to the liver and have spread elsewhere that you cannot resect, but still the bulk of the disease, 90–95%, is in the liver. So in those patients, there are several strategies that now are used in the regional therapy, and the main focus of this regional therapy is to intensify liver treatment. And we'll talk about each one of those. One is called DBIRI, and that stands for drug-eluting beads with irinotecan. Okay? And the other two are hepatic arterial infusion with chemotherapy and radioembolization with yttrium-90. So drug-eluting beads with irinotecan, or DBIRI, is basically what we also call chemoembolization. And basically what the interventional radiologist does here is cannulate or thread a catheter from the femoral artery in the groin, just like how we do with cardiac catheterization. And this catheter is threaded all the way through the aorta into the hepatic artery. So this is the artery that feeds the liver. And when possible, they basically cannulate this catheter all the way to the artery that feeds the tumor. And then they inject these tiny beads that carry chemotherapy. They're soaked with chemotherapy. And these beads will release the chemotherapy locally, so the idea here is to give a higher dose of local chemotherapy or regional chemotherapy within the tumor. The drawback of this procedure is that it can result in significant amount of pain. Usually there's fever associated with it. There is hospitalization associated with it. It has to be repeated. It's not typically a one-time procedure. Significant discomfort associated with it. And there's very little randomized studies that have been performed. There's only 2, and both of them are small phase 2 clinical trials. There's no phase 3 data with it. However, there is data supporting that it does shrink the tumor. This is a clinical trial that is a very small randomized trial. You can see it's only 35 patients versus 35 patients that has looked at patients who have metastatic disease to the liver who underwent prior chemotherapy. And then those patients were randomized to undergo chemotherapy alone versus the drug-eluting beads with irinotecan. And this described a trend toward better outcome and overall survival in the patients who received DBIRI. There were a lot of criticisms regarding this clinical trial, and some including the fact that these patients had disease outside the liver that appeared to be better controlled on the DBIRI arm. Nonetheless, it does suggest that there is some activity to the procedure, and this can be considered on a select basis for patients with metastatic disease to the liver. This is a more recent clinical trial that has not been published yet that was presented at ASCO about a year ago by Dr. Martin. And on this clinical trial, it asked the question, well, can we add this regional chemotherapy, this chemoembolization, to the patient's chemo? So now you're doing basically a double whammy where you're treating with IV chemotherapy, but you're intensifying as well with a regional chemoembolization with these drug-eluting beads. 30 patients received chemotherapy alone, 40 patients received chemotherapy plus DBIRI. And what this study showed is that when you look at any progression, there wasn't really any difference between both arms, which was somewhat disappointing. However, when you look at the liver disease control, those patients who underwent the drug-eluting beads with regional chemotherapy had a better likelihood of controlling the disease in the liver. The drawback is that we don't have any data yet as far as the impact on longevity with adding drug-eluting beads. The other drawback is that this procedure had to be repeated multiple times, which resulted in much higher, what we call severe adverse events in patients who undergo the procedure compared to chemotherapy alone. So as you can see here, people who got chemotherapy, only 15 patients out of, or 15 severe adverse events happened in the patients who got chemotherapy alone versus 57 severe adverse events in patients who underwent the chemoembolization or use of DBIRI plus chemotherapy. And so it is a procedure not without morbidity, but I think there is still a role for this procedure in select patients with metastatic colorectal cancer to the liver. So to summarize the role of DBIRI in metastatic colorectal cancer, clinically active, requires repeated treatments associated with a high rate of abdominal pain, nausea, vomiting, often requires 24 to 48-hour admission. And we still cannot rule out, is it the chemo that is absorbed in the body, because irinotecan has activity, that is adding to the activity, or is it the procedure alone? Because there has been no data on comparing FOLFOX plus DBIRI to, say, FOLFOX plus irinotecan IV. So I think that also needs to be evaluated further. So next, I will go over a couple slides about regional chemotherapy using what we call hepatic arterial infusion. And what hepatic arterial infusion is basically constant infusion of chemotherapy through the hepatic artery. So what the surgeon does is implant a small pump that uses a spring technology. You don't have any batteries, and the pump is filled with chemotherapy, and by filling the pump with chemotherapy, it pushes or collapses the spring, which tries to expand back slowly and therefore push the chemotherapy out. And this pump is connected with a small catheter that is cannulated into the hepatic artery. The chemo that is typically used with this is called FUDR, which is a cousin of 5-FU. And it is cleared about 99% in the liver, which means that the liver is able now to receive high doses, chew the chemo up so that it's not reabsorbed by the body. So the patient doesn't really have any side effects related to the chemo because it's all cleared by the liver, yet the chemo is administered to the liver tumors and therefore has good activity in the liver. The positive is that less systemic toxicity, side effects. The negatives is it requires surgery, it requires removal of the gallbladder, so it's an open surgery, it's a laparotomy. And the other risk is that there's sometimes dysfunction of the pump. It doesn't work in all patients. It may result in scarring of the bile ducts, which cannot be fixed surgically, and some of those patients require biliary stents. Biliary sclerosis occurs in about 2 to 5% of patients undergoing this procedure. We have to counsel patients about these side effects because biliary sclerosis can be a significant problem to deal with the rest of the patient's life, along with treatment with chemotherapy. So why do we think that hepatic arterial infusion works, and where do we use it? We know that it works based on one large study that, well, moderate or mid-sized study, looking at about 130 patients, half divided to get IV chemotherapy, half divided to get the regional therapy. And by controlling the liver disease, as you can see here, that the median time to liver progression, so the time where half the patients the treatment has continued to work and half has stopped to work, is about 10 months in the patients who got the hepatic arterial infusion, about 7.3 months in patients who got the IV infusion. And this translated in a better likelihood of survival. You can see that half the patients survived beyond 2 years with the pump, and half survived beyond 20 months with the IV chemo. So we know that controlling the liver disease, preventing the liver failure, does help. But this was not a very substantial improvement in overall survival. And the comparison arm here was 5-FU-leucovorin alone. We have much better chemotherapy now. So I don't think this procedure should be used in untreated patients with metastatic colorectal cancer because we have much better chemotherapy, and this procedure can be associated with significant morbidity, discomfort, and likely or possible biliary sclerosis. What about patients whose tumors stopped working, stopped responding to all chemotherapy? This is a recent update from ASCO last year looking at using the pump for patients who progressed on everything. And this is from Memorial Sloan Kettering. 23 patients who had failed on all systemic chemotherapy. About 1/3 of those patients, when they placed the pump in and used FUDR, had good shrinkage. 40% had stabilization. And if you look at the time to progression, it took about 5 months on average before this chemo quit working. I have to say the limitations of this study is that they also added IV chemotherapy to the pump. So this is not only pump effect. Most of those patients had intravenous chemotherapy on top of the pump, despite the fact that the intravenous chemotherapy had quit working. But the investigators were trying to find some synergy or a positive interaction between the IV chemo and FUDR. Now, because the impact is moderate here, and because this requires, again, a surgical intervention, if there are other options of therapy, this is not the first thing that jumps to mind in somebody who's got liver metastases that is not amenable for surgery, especially if there are other options of therapy. So this is a slide that summarizes the limitations that I just mentioned. So now I'm going to take you to radioembolization with yttrium-90 microspheres. So this is now regional therapy trying to take advantage of radiation treatment. And basically the procedure involves, again, cannulating the femoral artery and threading a catheter all the way through the femoral artery into the aorta, and then cannulating the aorta to go into the liver using the hepatic artery. These tumors, the liver metastases of colorectal origin, rely on the arterial, on the pink blood for their growth. So if you inject the chemotherapy, or if you inject radiation beads through the hepatic artery, that hepatic artery is going to eventually end in the tumors, and that's where it's going to direct the beads. And since the normal liver does not receive its blood supply from the artery but receives it from the portal vein, hepatic artery-directed treatments are less likely to impact the normal liver. So what are microspheres or resin microspheres, or what is, surspheres, microspheres? Surspheres, microspheres are very tiny beads that are about 32 micrometer in size, so basically non-visible. and they emit yttrium-90 for a duration of about 2 weeks. So this bead has radiation, the yttrium radiation continues to be emitted for a period of about 2 weeks. After approximately 2 weeks, less than 5% of the radiation remains in the beads. And the depth of the radiation is really only in a few millimeters. It doesn't go beyond 1 inch, and then therefore it's a very safe procedure. And the patient can have this procedure on an outpatient basis. So what typically is done here, after appropriate planning, there's a couple tests that need to be done to look at the circulation in the liver. But after those are done and it is found that the circulation in the liver is appropriate, the patient will come into the radiation interventional radiology suite, and then an outpatient procedure is performed where the artery, the femoral artery, is cannulated, and then the vial of beads is used and injected through the hepatic artery, and the patient is observed for a few hours, and then the patient goes home. Now, these beads are tiny enough that they can go through the arterioles, which are very small arteries. They will reach the tumor, but they are big enough they cannot pass through what we call capillaries, which are the tiniest branches that branch off out of the arterioles. So really, when they hit the tumor, they lodge in the tumor. And because they're hitting the tumor in the millions, they will basically cover all the tumor and emit radiation all through the tumor and basically kill the cancer using apoptotic measures and DNA damage. So how safe is this procedure? This procedure is relatively safe. Readmission rates is very low, and it's almost nil. The most common side effect after this procedure is fatigue. Patients have mild to moderate fatigue. They're a little bit tired for about a week after the procedure. The rate of fever or risk of fever is very low. Very few patients will hit 101. Usually it's very mild, in contrast to chemoembolization. Nausea and vomiting, when they occur, are usually mild, and patients do not require any intravenous hydration. The grade 3 toxicity is what is considered a serious side effect, and as you can see, most of the side effects are grade 2, not grade 3. Those of concern are ulcers in the stomach, and historically that's been about 5% of patients. Although with better techniques now, I think the risk of stomach ulcers have decreased significantly and are closer to about 1 to 2%. There's also the concern of liver failure, similar to other liver-directed therapies. Those are approximately 1% or less of patients who undergo this procedure. So why do we use microspheres or surspheres, microspheres, and when do we use them? So I don't want to go over the details of this slide, but what this slide shows here is 2 randomized clinical trials, meaning 2 studies where there are 2 comparison arms. One comparison here has been the hepatic arterial infusion, so giving chemotherapy directly in the liver, or giving chemotherapy directly in the liver but adding to it the beads. And by the way, the radioembolization is a one-time procedure. It's not a repeated therapy. So in this study, they get a one-time treatment to the whole liver. And what you see here is that the response rate in those patients who have liver disease only tripled with the addition of beads to chemotherapy from 18% to 44%. The likelihood of progression in the liver dramatically decreased, with a median improved from 9.7 months to 15.9 months, and resulted in a trend in improvement in overall survival. Those patients on FUDR, some of them did undergo radioembolization with surspheres after they progressed, and therefore the difference in overall survival was less than the difference in progression. This is another study that looked at IV chemo versus IV chemo plus surspheres, and you can see that the patients who underwent IV chemotherapy here had the likelihood of the major shrinkage was, in this particular study, 0 versus 72.7% with the radiation beads with surspheres, and also the time to progression went up from 3.6 months to 18.6 months. And more recently, it has been shown that the chemotherapy with the more modern chemotherapy, FOLFOX, can be safely added to surspheres, but with dose modifications. And this has been the subject of the SURFLUX trial, which we will talk about in a little bit. This device has also been investigated with what we call second-line chemotherapy, meaning patients who got one type of chemo and then quit working. and has been combined with irinotecan. That's another chemotherapy that we use for colorectal cancer. And what has been shown on this particular study is that about half the patients had a major shrinkage, more than 50% shrinkage, which compares very favorably to irinotecan alone in the second-line treatment, where we see 10% shrinkage. So again, it shows the feasibility of adding it to different backbones of chemotherapy. So how about patients who have metastases to the liver of colorectal origin who have progressed on all standard chemotherapy? This is a very, very important clinical trial because it is really level 1 evidence. These were patients who have had no further options of treatment and had metastatic colon cancer to the liver. And what this study did is randomize patients, or at a flip of a coin, either to receive a continuous drip of 5-FU for 21 days, and then repeat that every 4 weeks, versus receiving the same chemotherapy and in combination with CRCWebinar with the radioembolization, and the radioembolization was given once here. I apologize, I think it's 2 weeks on one week off with the chemo. But what you see here is that patients who received the beads, half of them had no progression in the liver beyond 4.5 months. And those who did not, who got the continuous drip, it was only 2.1 months. And about 70% of patients who received the beads had no progression at 2 months. And with the 5-FU alone, it was only about 20-25% of patients. So this study has shown us that for patients who have metastatic disease to the liver, who have no options of treatment, now we have an option that can control their liver disease. I'm going to show you a couple cases from our practice. And I'm going to show you how we integrate this modality in the first-line treatment, meaning the first chemotherapy type that we use before in a patient with chemo-naive disease, no prior chemo, how we use it in the second line, and how do we use it in the refractory setting. So I'm going to start with a case of a 74-year-old male. This is a musician who has metastatic disease to the liver. This patient, we treated him with chemotherapy. We gave him combination chemo plus Avastin, bevacizumab, had stable disease for 4 months, and then we kept him on maintenance therapy. The patient did not tolerate chemotherapy very well. We had to scale back to 5-fluorouracil Avastin. And then his tumor marker started going up. This is July. You can see the tumor marker going up from 500 to 1700. His tumor had increased. He had disease outside the liver. We couldn't cut this out. So what we did, we radioembolized. We used CRCWebinar, and this was outpatient. The patient felt well, just minimal fatigue. And only 2 months later, you have major decrease in the tumor size from before to after, major dip in the CEA. We did not have to change the backbone. We did not have to intensify his chemotherapy. We kept him on 5-FU Avastin. It took about 14 months for this patient to require a more aggressive chemotherapy from the initial diagnosis by integrating radioembolization in his management. This is another case of a 72-year-old male who has lymphoma and metastatic colorectal cancer. Again, this guy has RAS mutation, so cannot receive anti-EGFR therapy. We gave him FOLFOX, which is standard of care. Again, after 4 months, had too much neuropathy. We couldn't continue oxali. Kept him back on 5-fluorouracil Avastin. But then his CEA also started going up, and he had slight increase in his tumor. And this is what you can see here, increase in CEA level. So again, we radioembolized the whole liver. These are the tumors. They were progressing. And you can see that there is a decline in the tumors before and after. And we were able to continue 5-fluorouracil and Avastin on this patient without progression for at least another 6 months. This is post-radioembolization in the same patient, and you can see the stable disease, no progression after radioembolization 5 months, this is about 4 months later. So the other strategy for this is using it for patients who cannot tolerate chemotherapy. This is an 81-year-old female who received a very mild chemotherapy, 5-fluorouracil and bevacizumab, and received it over a period of 10 months. But then she really couldn't handle it anymore despite dose reductions, and she had only liver disease, not amenable for resection. We ended up doing radioembolization with capecitabine. This is her PET scan. What lights up is cancer. So this is the right lobe of the liver. We did a CRCWebinar treatment to the right lobe. The tumor disappeared. But because we hadn't treated the left lobe, the left lobe tumors increased. So what we did is we treated the left lobe after 2 months. And this is before treatment on the left lobe. You can see the uptake, and you can see after treatment. Completely normal PET scan. Her liver remained cancer-free without any activity by PET-CT about 10 months after that. This is a patient who is even older than that, who has multiple, actually 64-year-old, who has multiple comorbidities. We treated her with chemo, developed metastatic disease to the liver, tried to resect, had a recurrence, could not tolerate chemotherapy. This is June 2014. We radioembolized with CRCWebinar in July, and you can see the tumors are much smaller still back in March 2015. So this is about 8 months later, still ongoing response. I can give you numerous other cases. This is a second-line chemotherapy, but for the sake of time, we can skip this second-line treatment, but it's the same message. This is with irinotecan. We were able to control in a second-line setting. I'll take you to some refractory cases. This is a 52-year-old who was sent to me 2 years ago for what we call phase 1 clinical trial. When we looked at his disease, it was predominant in the liver, and we thought we could help him with radioembolization rather than go on experimental therapy at that time, and that was 2 years ago. This is his disease in the liver. This is July of 2013, and you can see the CA was about 1,000. We used CRCWebinar in September of 2013. This is when we, this is post-radioembolization a few weeks later. This is a couple of months later. Disease completely stable. CA went down from about 1,000 all the way to about 20. Now, we did add chemotherapy back here, and we maintained this patient for about a year. And then a year later, so this is now this is March 2014, in March, April, CA started going back up. So you can repeat this procedure if the patient have a subsequent progressive disease. We re-radioembolized using CRCWebinar in April of 2014, and we recontrolled the disease. You can see the enhancement, the white color here from the vascularity, and now it's almost a dead tumor that is black. And you can see a decline in CEA. This is another gentleman, 45-year-old, with extensive metastatic disease to the liver with KRAS mutation. You see glowing and then black in the liver. This is all tumor. This is the time of presentation, almost complete replacement of the liver. We treated with his chemotherapy and look at the response with chemo, before chemo, after chemo. Eventually, the chemo quit working, and the CA started going up. So we radioembolized. This is where we did CRCWebinar. And you can see now that these hyperdensities in the liver did shrink, and the CA declined, and we were able to control the liver subsequently for at least another 8 months without progression in the liver, with a normal PET-CT in the liver, no uptake in the liver when this was glowing at the time of presentation. So I hope with these cases it gives you an idea as to where to use this procedure, but it can be integrated. It has to be individualized. Not every first line should receive it, not every second line. We don't like to repeat this too many times because it may actually damage the liver if you do it repeatedly. But a one-time procedure is very safe. People who respond very well, especially if it's one region of the liver only that is repeated, it's very safe to repeat as well. You can use it with multiple lines of chemotherapy. And, in summary, it can be used with different backbones of chemo, whether first line or second line or refractory. Most of the use in the United States right now is in the refractory setting, and patients will progress on everything. Procedure is done on outpatient, safe, well tolerated, and is an effective tool in the treatment of metastatic colorectal cancer. I will end it with this clinical trial. This is what is called the SURFLOX clinical trial. This is a very large clinical trial that was done across the globe, international study. And what this study is answering is, can we improve the outcome of first-line chemotherapy by adding radioembolization with CRCWebinar? So half the patients got CRCWebinar plus FOLFOX, half got FOLFOX alone, with or without bevacizumab. The primary endpoint was progression-free survival. How long does it take to progress? And it included patients who have predominant liver disease. A portion of those patients had minimal amount of disease outside the liver, and another portion had liver disease only. This will be presented at ASCO, so we don't have all the data out. However, the abstract is out. When we look at progression anywhere in the body, there was no difference. However, what is very promising with this is that the progression in the liver was delayed significantly by adding radioembolization. On average, it took 12.6 months in patients who did not receive CRCWebinar to progress with first-line chemotherapy. It took 20.5 months on average to progress with adding CRCWebinar to chemotherapy. That means there's about a 31% decrease in progression rate if we look at something called hazard ratio, because this is average. So there is significant control of liver disease. What we hope will happen is that this will translate in lesser likelihood that the liver will fail secondary to hepatic involvement with cancer, and that this will translate an improvement in survival. The overall survival data is not out yet, and we are all awaiting that data, but we know that patients who had liver disease, which are the patients enrolled, that the response in the liver was higher in the patients who got radioembolization than those who did not. So this is the last summary slide. I think it's fair to say liver-directed therapies should be focused on curative intent when feasible. So that's the surgery. We talked about that. For non-resectable liver metastases, I think there may be a role for regional therapy here. Radioembolization holds a lot of promise because it has minimal toxicity, can be done on an outpatient basis. There's a fair amount of data for the refractory patients who should wait for the overall survival in the first-line setting. Other options include chemoembolization and hepatic artery infusion that could be used in very selective cases. In my mind, at this point, for non-resectable disease, radioembolization is a favored strategy in patients with chemo-resistant disease, with liver-limited disease, or liver-predominant disease. So I'm going to end it up here, and I'm happy to take any questions.
Thank you so much, Dr. Fakih. We really appreciate your presentation, and we've gotten a lot of really great questions in, so thank you so much. I'm going to go ahead and switch over to our question slide, and that'll just take me just a second. All right. So what we have here, so with our questions, Dr. Fakih, we've had some questions come in on sort of with stage 3 colon cancer, and I know that you spoke to this at the beginning of the presentation, but is the cancer more likely to come back in the liver and not in the colon? And if you could speak to that a little bit more.
Sure. So in general, local relapses are not very common in patients with colorectal cancer, but they can happen. There higher likelihood of having a local relapse, meaning in the area where the colon or rectum used to be, for rectal cancer than colon cancer, and that's because the pelvis is narrow, and there's more likelihood of having residual microscopic disease in the bed of the tumor, in the bed of the rectum. So that's called, when that recurrence happens, that's called a regional recurrence or a local recurrence. For rectal cancer, the rate of, because rectal cancer, they will get radiation if they're stage 3 disease. For stage 2 and stage 3 rectal cancer, really the risk of local recurrence in the pelvis is, with adjuvant therapy, is about only 6 to 8%. For those same patients with rectal cancer, the risk of distant relapse, if we lump stage 2 and 3 together, is, arguably somewhere around 30% of patients. And I'm not talking about this particular patient. I'm just giving general statements, and that's averaging out all these stage 2, stage 3 disease. For colon cancer, for stage 3 disease, if we look at all stage 3, stage 3A, stage 3B, and stage 3C together, with FOLFOX chemotherapy in the adjuvant setting, still about 30% of patients will have a recurrence, but really no more than a couple percentage will have a recurrence at the site of the anastenosis where the colon is reconnected together. So the local recurrences are very low. There is a subgroup of patients who have a higher risk. Those are the ones that we call T4 tumors, and where the tumor has breached out completely and perforated. Those may have a little bit higher risk of local recurrence. Patients who have involvement of surrounding structures, for example, if the colon tumor has eroded, if the sigmoid tumor, for example, eroded into the bladder, those have a higher risk of local recurrence. So based on the pathology of the patient, the treating physician should be able to tell the patient if they have a higher risk of local recurrence or not, but in general, local recurrence is low. As far as developing a new colon cancer in the rest of the colon, which I suspect that's the question, that risk is higher than the rest of the population for a patient who already had colon cancer, and therefore those patients are followed more closely with colonoscopies, and that's the only way to look for another new colon cancer or a polyp before it becomes colon cancer. And in general, a repeat colonoscopy should be done 1 year after surgery in a patient who already had a full one prior to surgery, and it should be repeated every 3 to 5 years if the colonoscopy is negative. With those measures, the likelihood of suffering a serious second colon cancer that puts the patient at risk is very, very low. So still the spread away from the colon is the highest limiting factor in the longevity of patients. As far as to where does it go, colon tends to go more to the liver. We now know that molecular markers may also dictate the higher likelihood of spreading in one way or another. So, for example, a small percentage, 10% of patients have what we call BRAF mutation. Those may be more likely to go to the peritoneum, tend to be a little bit more aggressive. The RAS mutant tumors tend to have a slightly higher chance of involving the lung, and the RAS wild-type tumors less so, involving the lung, more the liver. But still, the liver continues to be the more dominant organ with recurrence among all organs.
And related to that, does having the BRAF mutation complicate treatment at all for these liver therapies?
Which mutation? RAS mutation?
I think it was the BRAF, the BRAF mutation.
Oh, BRAF.
Yeah.
Yes. So BRAF mutation it's very important for every single patient who has metastatic disease to know upfront what is their RAS mutation status. So we don't look only at KRAS, we look at KRAS and NRAS. And we look at what we call exons 2, 3, and 4 mutations. About 50% of patients with colorectal cancer will have either KRAS or NRAS mutation. About 10% of between 5% to 10% of patients will have what we call BRAF mutation. BRAF mutations are more aggressive and more resistant to chemotherapy. However, there are many drugs that are now in development in the management of BRAF mutation, and with very promising data coming out of those. So patients with BRAF mutations should be encouraged, in my mind, to seek an opinion in a tertiary care center or in a practice that has access to clinical trials and discuss the benefit from clinical trials. We know that BRAF inhibitors in combination with anti-EGFR therapy have very promising leads. That data has been presented at ASCO last year, and there's follow-up at ASCO this year as well, confirming those findings.
Thank you. So are there any symptoms that a patient would experience that would hint that they do have a metastases to the liver?
Unfortunately, the patient should not wait till they have symptoms, and that's one of the reasons, for surveillance in a patient with resected stage 2 and stage 3 disease. I think all these patients should be encouraged to have a tumor marker evaluation initially every 3 months for the first 2 years, and then every 6 months for an additional 3 years for a total of 5-year follow-up, as well as periodic CT scans. The problem is that the liver has no sensors for pain. And so things can grow in the liver, and the patient will not be able to tell that. And the only time the patient will have symptoms from a spread to the liver is when there is a high burden of disease in the liver to the point that the liver is stretching. And when the liver stretches, the capsule of the liver, which has the pain sensors, starting giving signals that the patient has discomfort and pain in the right upper quadrant. But usually you only see that when patients have more than 30% liver involvement. So there are no early signs of liver involvement by clinical symptoms.
Okay. And as far as the surveillance goes, is a PET scan more telling than a CT scan to observe the progression of metastatic liver disease?
Well, that's an excellent question, and unfortunately there is this misconception that a PET scan is better than a CT scan for following patients with metastatic disease. The truth is, a CT scan with IV contrast in a patient who does not have a fatty liver is probably better than a PET CT in following these patients. And because what happens is that the PET scan really depends on the ability of the tumor to take sugar, and basically uses radioactive, what we call FDG, radioactive sugar as a method to find the cancer. The problem is that the chemo stuns the tumor sometimes without killing it. And when the tumor is stunned by chemotherapy, its ability to take sugar is diminished. So you can have a tumor that is 1 inch in size in somebody receiving chemotherapy and have a perfectly normal PET scan on the liver. And the same patient will undergo a normal CT scan with iodine, and you will see the tumor. So it is, if the PET is negative, likely the tumor is responding, but it doesn't tell you how much. But there are instances where it actually may mislead you, thinking that there is good shrinkage when there is no shrinkage, but the tumor is stunned. In addition, it is important to recognize that there are subtypes of colon cancer, what we call mucinous cancer, that have a lot of mucin in it, and mucin is a gel-like substance that the colon produces, and the colon cancer maintains the ability sometimes to produce. And tumors that are called mucinous tumors, the bulk of the tumor is mucin, and mucin is inert and does not take radioactive sugar. So those, many times, these mucinous tumors in the liver will not really light up on the PET and will not be seen on a PET. So I think the best thing is to discuss with a physician as to the merits of one test versus another. Sometimes a PET CT is not very good, and the patient has very fatty liver, and the CT is also limited, and we have to do an MRI. And so most of the patients, a CT with contrast is the best way to follow up.
Okay, great. So we've had several questions come in about different chemotherapy agents. We've had a lot of questions come in on Avastin, so I'm not sure in what detail you'd like to address some of these, but one specifically, when using chemo to try to make the liver resectable, do you ever substitute Xeloda for 5-FU?
So Xeloda plus oxaliplatin, a regimen called Xelox, is considered equivalent to a regimen called FOLFOX. So I think it is appropriate when a physician is considering using FOLFOX to consider substituting 5-FU by Xeloda and using Xelox. The addition of Xeloda to irinotecan, on the other hand, a regimen called Xeliri, has not compared favorably to a regimen called FOLFIRI when FOLFIRI is considered. And if I am using a triplet chemotherapy, what I use FOLFOXIRI, I never substitute 5-FU with Xeloda in that setting because the regimen becomes way too toxic on the patients. So it depends on the situation, depending on, are we looking here at downstaging for resection? If it's a situation where the goal is to control the disease and FOLFOX is considered, I think Xelox is appropriate. There's a little bit trade-off. Xelox, patient is more comfortable, they don't have to wear the infusion pump, but actually substituting 5-FU with Xeloda increases the diarrhea rate considerably and has what we call hand and foot syndrome, which is less likely to happen with 5-FU alone. So there's a little bit extra side effects associated with it from the perspective of diarrhea and hand and foot syndrome. So I discuss these things with my patients, but yes, you can substitute in the setting of oxaliplatin.
Thank you. We had a question about if you could speak at all briefly to isolated hepatic perfusion, and is that something that differs from the hepatic arterial infusion?
Yes, it differs. You know, the isolated hepatic perfusion is not being done at a large scale in the United States. I think there's only a few centers that do that. It's a technique that has been initiated at the NCI a while ago, and I'll be honest, I don't have personal experience with it, but what I can tell you is that it is more demanding, and the data is really not there yet with colon cancer. It's been used more so with melanoma in the past, and now that there's more effective treatment for melanomas, I would suspect it is used even less. It is basically what is being done here is you isolate the infusion in the liver and the outflow of the liver, and you have basically a closed circle of perfusion in the liver where what you're infusing in the liver is not going back to the patient. And so you can infuse a high doses of chemotherapy through that. And the drug that has been used in the past for that has been called melphalan, which is not a drug used for colon cancer. The NCI at one point evaluated patients with colon cancer with that procedure, but the outcome has not been that robust. So it has really taken a little bit of a backstage.
Okay. Thank you so much for that information. I think just sort of kind of wrapping up with our discussion and any insights that you have. I know that we had talked about, the procedure with the Serflox data and that sort of thing. And do you think that more cancer centers are going to be able to conduct those procedures, or do you know what the access looks like right now for patients interested in those procedures?
Well, most metro areas have that procedure in multiple practices. My understanding is that there's probably more than 200 centers across the U.S. that do radioembolization. So I think the access is there. Probably it's not there in small cities or rural areas. But since it's an outpatient procedure and it's not a repeated therapy, it's something that a patient can always discuss with their medical oncologist if they are candidate for the procedure or not, or if so, if a referral can be made to a larger cancer center to perform the procedure.